Thanks, Bert. Very nice to be here. When I was called to talk about this, about something in your department, I suggested this topic because that was the paper I was working on that day, and it's been a while. And the paper actually was published last week, so that's how long it's been. But the other day I was sitting down and starting to prepare some slides, and I realized there's not all that much to talk about in this paper. It's pretty straightforward. I can do it in 20 minutes before Tyler leaves. But so I figured I'd use the occasion to say something a little bit more about the broader program of research that we're doing on suicide prevention, and that goes along with several interesting institutional things that have happened in the last few months. One being that Miguel Hernan and friends have gotten a training grant in studying suicide, and we're looking for bright, interested epidemiology students who are interested in that program. We also just recently got a P50 award, a center grant, with MGH to do a whole series of studies about suicide prevention, one of which is an experiment to evaluate the effects of the model that we developed here. And the third is that the Veterans Administration, which is a data set I'm going to talk about today, has now established a national center for suicide research, which is at the Boston VA, which we're collaborating in. So there's all kinds of possibilities going on in Boston, and in conjunction with the training grant, we're pulling together these three groups and having a monthly meeting of people who are interested in suicide. So of those of you, any that are interested, Frankie is one of the pre-docs in the program. We would welcome you to contact us and talk to Miguel maybe about this or others. So let me start out by telling you a little bit about the problem. Generically, the U.S. suicide rate has increased by more than a third since 2000, 15% over the past decade. Suicide is the ninth leading cause of death in the United States. Now it's the second leading cause of death among young people in the United States. Close to 50% of the people who die by suicide show up in an emergency room within 12 months before the suicide. So it's really the biggest entry point for touching base with these people, and a risk of suicide associated with an ED visit is the relative risk is 2 for a year. It's a 10.8 for if you came in the last week, and the problem that is posed by that set of statistics is as follows. One is you see somebody who comes in with suicide ideation or attempt or aborted attempt in an ED. What you're supposed to do is evaluate suicide risk, and then if you think of them to be at risk, to hospitalize them and stabilize them and develop an 8-patient treatment plan and have a warm handoff to the outpatient treatment provider. But there are a series of unknowns in each of those things. One is, how do you know whether they're at suicide risk? There have been several studies done that are really interesting that ask ED doctors to tell whether they think a patient is likely to die by suicide in the next year or the next 6 months or 3 months, and then follow these people over time and see how good is the prediction. And the data are very consistent across time, which is that you could flip a coin and do as good a job as an ED doctor can do. I mean, there's absolutely no association at all. Pretty amazing. So there have been a number of studies in the past decade to try to develop machine learning models to predict suicide. And, there's kind of the debates about what are the best features and what are the best classifiers and all that kind of stuff. And are there biomarkers and so forth? And that's a growth industry. But there's a lot of interesting stuff going on there. And part of the thing has to do with where do you start. Tianci is doing some things with us in the center on this, but there's sort of these touch points that when people come for their annual physical exams, for example, we can actually do a pretty good job of seeing who's at risk of suicide by pulling out all the data we have people at that time. And this is something that in the VA and the DoD is becoming something of considerable importance, because over the past couple of years, there's been a new rule that you have to ask about suicidality. So it used to be that when people would volunteer it, it meant one thing because it was sort of bubbling up, and the fact that they were disclosing it on their own is sort of more predictive. But if you ask everybody, have you thought of killing yourself? It turns out a surprisingly high number of people say, yeah, well, I mean, I guess every once in a while the thought has crossed my mind and so forth. And primary care doctors are ill-equipped to figure out what to do with that. And so now there's a lot of interest in figuring out how do we, at the point of contact of the annual physical, make an assessment of whether this is real suicide risk or not. We know from the from the VA studies that have been done over several years now, where the PHQ-9, which is a depression screening scale, the 9th question asks about, have you thought that life wasn't worth living? And a lot of people say yes. If you, that's now been administered to about 25 million times in the VA in annual physicals. And when you then see who dies by suicide over the next 90 days and go back and see what did they say to that question, you discover that it's true that the people who say, I've been thinking about suicide, are about 3 times as likely to die by suicide. But also it's the case that 70% of the people who die by suicide say they never thought about it. So asking about suicide explicitly is not a great way of figuring out who's going to commit suicide. There's a whole bunch of other stuff. And there are now some really interesting models among people who say, I'm not suicidal, to predict which of those is going to commit suicide. And we can do a pretty good job of predicting this. Now, whether that has a positive net benefit in doing the intervention depends on a bunch of other things about what the intervention is and what the impact of the intervention, what the cost is, and all that kind of stuff like that. But we can, in fact, find a pretty substantial number of people who die by suicide in a relatively small percentage of the population of people who we predict to be at high risk. So that's the first thing. The second thing is, should we hospitalize them or not? As I said, the standard of care is that they should be hospitalized. In America, about 50% of people who are suicidal who come to an emergency room are hospitalized. The other half are not, because their wife says, no, don't hospitalize me, doesn't want to be hospitalized. I'll take them home, I'll watch them, there's no bed. If they refuse to be hospitalized, you got to go get a court order, and a lot of times they end up not being hospitalized. And that's what we'll talk about later today, but that's a big issue. And then developing an outpatient treatment plan is a whole other thing. What treatments are the kind of things that help people with suicide? And the challenge from a precision treatment perspective is that for lots of disorders, there's no one treatment that's best for everybody. But it's more true for suicide, and the reason is that suicide is not a disorder. Suicide isn't a reaction to things. There's some bipolar people who commit suicide, some depressed people, and some people with non-affective psychosis. And what you do with those people is wildly different depending on things, So how you do that is tricky, and there's an awful lot of work being done on coming up with the best outpatient treatment plan in a stepped care kind of approach. And our kind of extended group at Harvard, including Matt Nock, who's the chair of the psychology department at Harvard College, who runs a big suicide prevention intervention center there. We're now working with the Department of Defense to try to put in place an integrated system for how to prevent suicides. And it's an interesting thing because over the course of time, I only came to realize this recently, the Army, Navy, Air Force, Marines all had their own healthcare system. So Walter Reed is an Army hospital, and the hospital in San Diego is a Navy hospital, and you can be in the Army and end up in a Navy hospital because that's the closest one, but there's a thing called the Surgeon General of the Navy, and he's in charge of the Navy hospital, the Surgeon General of the Army. And in the past few years, as part of this reorganization of the military system, there's been an effort to do away with that, to have Department of Defense things. And we now have this situation where the Surgeon Generals of the various services have now been relegated to only being responsible for what happens overseas. And in the United States, there's one big thing. All hospitals are Department of Defense hospitals now. And instead of the Surgeon General for the service running it, there's a civilian administrator, which, as a person who's been working for 15 years or so in the Army, I'm very delighted with, because whenever we get to the point of getting to the Surgeon General and talking to them about what you want to do, that's a person who's been in the Army for 35 years, which means they have 3 more years because they're going to retire. And they don't want to try anything new now. So they just don't want to rock the boat. So as soon as I get to somebody at the top, they immediately are these Luddites, you know. We now have a system where there's a new guy, Dr. Martinez Lopez, who came from like one of the B8 accounting firms, who's now the head of all the military health system, and has said to the head of research for the DoD, what the hell are we doing? The suicide rate is going crazy. We have to do something about this. How are we going to figure this out? And fortunately, since, as I said, my group and others that I work with at the Uniformed Services University have been here for 15 years doing research, and we're buddies with the head of research, he said, I happen to know some people at Harvard who could help you. And so we've now got to talk to this guy. And he said, what could you do? And I said, well, we could do a lot, but it would probably cost, $30 million to start. And he said, where do I send the money? I mean, it was like, so we now have this team we're putting together, doing this series of things of, okay, so now at the annual physical, when we find people who are suicidal, what's the right thing to do? And there are probably 3 or 4 things to do. And no one of them is going to be the right thing for everybody. So we're now doing a 4-armed SMART trial. That's probably going to be $20 million just for that. But they say, they spend $20 million on hammers, setting things. It's just amazing the amount of money these people have. It's incredible. So it's pretty exciting times. So, okay. So that's what we're up to. Developing an outpatient treatment plan, a non-trivial thing. Today, I'm going to talk about, should people be hospitalized? There's several studies using simple propensity score methods. To say, well, look, these 50% who are hospitalized, the 50% who are not hospitalized after being in an emergency department with a suicidality, what difference does it make? And basically, the answer is it doesn't make any difference. The suicide rates are pretty much the same for people who are and are not hospitalized. There have actually been 2 trials that looked at the issue. Both of them were negative, but they were wildly underpowered. But you can do a meta-analysis of putting together these things. There's pretty much nothing there. You can argue about whether the propensity score models were good, which they probably weren't. But there's one big thing that we know that differentiates hospitalized and not hospitalized patients, and that is that it costs a hell of a lot more to hospitalize them than not to hospitalize them. But it doesn't seem to have much of an effect on treatment outcomes. This doesn't make sense, though, because if you're a clinician, particularly if you're an ED doctor, any ED doctor will tell you that they can tell you of particular instances of a patient where they know for a fact in their heart of hearts that if they had not hospitalized this guy last night, he'd be dead this morning. I mean, there's just no doubt about it. And so it's really hard for them to believe that the decision to hospitalize makes no sense. There are other people, of course, dialectical behavior therapy people, who are really opposed to hospitalization and say that a hospitalization could hurt people. You've got to figure out how to learn to deal with all these impulses out in the community. If every time somebody kind of puts you in a cocoon, you never learn those skills, and in the long run, it's going to hurt. It's conceivable, of course, that there's heterogeneity. And in general, since I see that most of the people sitting around here are students, it's a terrible idea to look for heterogeneity in situations of this sort. Where you're much better off is when you're dealing with a trial where you know there's some effect. It's a relatively small positive effect, but you suspect that it's really a big positive effect in a subsample and it doesn't have any effect on it, but there's something to work with. the idea that there's nothing going on in the aggregate, and it just so happens that there's a positive effect in one group that exactly equals the negative effect in another group, that is pretty unlikely. So I wouldn't recommend this as something to do in general, but it turns out that we were working with a big VA system where we were able to look at this inexpensively at the margins and not have to spend an enormous amount of time tuning the data, because we worked with Stefan Wagner doing generalized causal forests, which are sort of pretty easy to run and just sort of see what you come up with. And lo and behold, things worked out, and we're now in the course of doing a couple of experiments about this. So the design is this: there are around 200,000 people in the Veterans Health Administration system between 2010 and 2015 who came to an emergency room either because they had just made a suicide and they come in an ambulance, or they were suicidal and the wife took their gun out of their hand and called the cops, or because they were thinking about suicide, something like that. The target variable of interest to us is, were they hospitalized? Yes, no. The outcome of interest to us is whether they subsequently, over the next the next 12 months, either died by suicide or made a non-fatal suicide attempt. And the predictors we looked at were all the standard structured administrative variables you have in healthcare systems. But I say here in the VA, not only VHA, by which I mean that the Veterans Administration is more than a healthcare system. They do student loans, and they are a mortgage company, and they have homeless programs, and they have all kinds of stuff. And so we're able to get lots more data than you would typically get by just analyzing something from a claims database. And in addition to that, because it's a national system and because we have geocode data on people's addresses, we're able to look at the neighborhoods where they live. And so we can say, here's a person who is a single who lives in a neighborhood that's a high transient neighborhood where the average income is $30,000, the opioid death rate is X, and so forth. So you get a lot more information. We also have an NLP data set of clinical notes that's been integrated for VA, so we're able to look at unstructured notes, and in emergency departments, they're very rich notes typically, so that's something we really. And we use, as I said, generalized random forest to train the model in a 70% training sample, and then to evaluate the model in the remaining 30% test sample. So real quickly, here's a propensity score, sort of a standard propensity score weighted estimated average of treatment effects of psychiatric hospitalization. And we divided things up by diagnosis, which turns out to be a critical thing to do, and also look separately in the 3 rows at suicide ideation but no attempt. 84% of all the people who came into the VA emergency room, they were thinking about suicide, but they hadn't made a suicide attempt. There was a small group of people who made a suicide attempt in the past week, but it's not the suicide attempt today. Those are people who came in last week with a suicide attempt today. They decided they didn't want to be hospitalized. They were sent home, and 3 days later they came back. It's only about 3% of people, but it turns out to be a pretty important little group. And things are different among them than the remaining 13% of the people who came in with a suicide attempt today. It turns out that over the next 12 months, in the first group, that 84% who just have been thinking about it, 10% of them either die by suicide or make a non-fatal suicide attempt over the next 12 months. In the other 2 groups, it's about 20%. So suicide ideation is, in fact, objectively less severe than making an attempt. But there's most of the deaths that we find associated with people who come to emergency departments are associated with coming in because you're thinking about it, because that's the 84% of the population. As you can see here, the aggregate effects, there doesn't seem to be much influence of hospitalization, using the term influence lightly because we're looking at an observational study. Not much of an association between hospitalization and subsequent suicidal behavior among the people who had ideation. There's a lot more action in and also much bigger confidence intervals in the middle group, which is tiny. And kind of in general, it looks like maybe there's some favoring hospitalization, pretty clear favoring hospitalization in the aggregate among the people who made a suicide attempt today, and here they are, the ambulance just brought them in, they have the pills in their stomach and they're getting flushed out. Should they get sent home or should they get hospitalized? When you do the causal forest analysis, you see the following. We divided the sample into quintiles. That's the x-axis here, where our estimate in the training sample is that hospitalization will help a lot or a little or no difference, or it'll hurt a little or hurt a lot. That's what 1 through 5 is. And what you see here is in the circle, that's what in the test sample, among the people who were, this is just using sort of doubly robust estimation, kind of a TMLE sort of thing to estimate these effects. What it looks like the effect, again, if you will, of hospitalization would be. So on the left, orange is non-affective psychosis, and the light blue is major depression, bipolar is the third, and everybody else is the other. These are about 30%, 30%, 20%, 20% of all patients. It looks like for people who are schizophrenic, non-affective psychosis, there's a big difference. It's significant between hospitalized and not hospitalized. If you're hospitalized, your risk of a suicidal behavior in the next 12 months is significantly lower than if not. When there's an arrow here, that means it's significant. If there's no arrow, it's not significant. So all the 4 on the left are significant. Significant advantage of being hospitalized. In the 3 middle groups, not so much one way or the other. And in the 5th group all the way to the right, in the last quintile, it looks like among the people who are hospitalized, they're worse, and things go up if you are hospitalized. Now, as I said, this is in a test sample. The predictions, these quintiles, are based on what we found in the training sample. So it's a pretty stable kind of set of results here. We're only looking at the people suicide ideation without attempt. That's this 84% of the sample. When you look at the small group of people who made a suicide attempt last week, they were sent home and now they're back again. Things are bounce around a lot more. It's a tiny sample. Most things are not significant, but in one case, we find that there is a benefit of hospitalization at the left tail for schizophrenia and at the right tail for other disorders. For the people who come in with a suicide attempt today, very clear evidence on the left that hospitalization is good. And it seems to trickle off into the second decile, and there's one case in the lower right where it looks like being hospitalized is bad in the other group. So that's essentially what we find. If you were to take that and simulate the results, you find something that looks like this, that if VA staff did what our model said to do rather than what they actually do, and I should note that there's essentially a correlation of like minus 0.07 or plus 0.07, something like that, between what they do. In other words, who should get hospitalized and who does get hospitalized, not much of an association. But if they were to do exactly what we say to do at the tails, the people who we say should be hospitalized, 100% of them get hospitalized, rather than the 60% or so that actually do. Of the people who we say don't hospitalize them, it's going to hurt them, 0% get hospitalized, compared to the roughly 55% who do right now. And the people in the middle do what you want to do. If that was the case, the overall number of suicidal behaviors among these ED patients, if our model is correct, would be reduced by about 16% per year. And if you read across the line, it's pretty similar for non-affective psychosis, bipolar disorder, depression, other. Most of that is associated with the biggest chunk of that is the suicide ideation without suicide attempt. That's because that's where the 85% of people are. But you can see every one of these things is in the direction you would expect. Interestingly, because of the boarding crisis we have in psychiatry now, and I mean, I know Deb knows about it, but you know, it's there are people waiting in hallways of emergency rooms around America for 6 days trying to find a bed, particularly young people. So there's a real crisis of not having enough beds for people. And it's noteworthy that if our system was put into place, the total number of people hospitalized would go down by 13%. So it's kind of one of these rare double win-win situations. You can reduce the number of suicides and also reduce the number of people who are hospitalized. So there are more people who are being hospitalized who really don't need it or who could be hurt by it than, and we're not doing anything in the middle, where, as I mentioned, where that's sort of 60% of the population where it doesn't seem to make a difference. You could argue if it doesn't seem to make a difference, don't hospitalize any of them. But of course, there's other reasons why people get hospitalized because of risk of suicide. So, but it looks like this is something that could have a pretty profound effect on the way business gets done in the VA, at least, as well as other segments of the healthcare system. So where do we go from here? Well, VA is now in the midst of having high-level discussions about whether they're going to put together a pragmatic trial for this. As I mentioned, we're doing this in the MGB system. We're working in the EDs in Mass General and North Shore hospitals. And it's nothing I said, by the way. Tyler already told me he had to leave. See you later. So we're doing this right now, but we're retraining the model for the civilian system to begin with, and starting about 2 years from now, we'll be randomizing people. We'll be randomizing ED doctors. Half of the time they will get this information as clinical decision support, and half the time not, and we will see what effect it has. It looks like, by doing the implementation work we've been doing now in VA, that this will have more of an effect on increasing the probability that people who we say should be hospitalized are hospitalized, because particularly now that the doctor is told he's on the edge, should I hospitalize something, this computer thing comes in and says, we think you should hospitalize, albeit we realize this is just the computer. You're a doctor and you know a lot more stuff than the computer knows, but if you only were to take into consideration all these things, and probably you don't have the wherewithal to look at all this other stuff that we know about where they live and what's going on and blah, 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 and what the, community one of the big things, by the way, I should mention is that we know that one of the strongest predictors here is how active the day treatment program is in the local area, because it's a national system. So it turns out that the strength of the outpatient system is a strong predictor of whether you should be hospitalized or not, and favoring the not. So, so we give this to the clinicians, but it looks like the clinicians are most interested in saying, well, if I had this and I was on the edge, should I hospitalize them or not? If you were to tell me hospitalize them, I would be much more likely to hospitalize them. But if I want to hospitalize somebody, I'm not going to not hospitalize them because some computer says to me, not hospitalize them. So it'll be interesting to see what effect it has. We talked to a couple of people in LA who said we would find this very useful for not hospitalizing too, because right now I have this guy sitting on a bed in a hallway for 3 days, and if you're telling me it would actually hurt him to be hospitalized, he would be happy to go for him and said, and I've got to make some tough decisions anyway, that's going to help me. But in a place like Madison, Wisconsin, which has a VA, and if you say the word suicide walking down the street by it, they will grab you and hospitalize you, because they have these 36 beds that they're all vacant and they're trying to fill them up. So there, we're going to have much more effect getting people to increase the probability that they get hospitalized. So we're doing that with VA, but we have a couple of things to do. We're updating our model. Right now it's only 2010 to 2015. And then we're also wrestling with what do you do with against medical advice people, because this model is really modeling as if we're looking at the effects of being hospitalized. And we're using it to recommend to clinicians that they should recommend being hospitalized, but the doctor doesn't decide who's hospitalized. And sometimes at the extreme, the court decides who's hospitalized. You know, if the patient says, I don't want to be, and they push a little bit, and you say, no, you can try to get, but that doesn't guarantee the person's going to. So there's not good structured fields for people who are discharged against medical advice. But the clinical notes has that, because just for legal purposes, the clinician wants to write down that I recommend this person's going to, and he's one of the ones I think is going to be dead tomorrow, and I want to note that I tried to get him, and they wouldn't do it. So, but it's taking a lot more work to sort of figure that out. And what do you do? The idea that there's some people who protest a little bit, but not so much, or should we only go to people who there was a court order and the judge decided they should be hospitalized or not? Should we estimate a model to see whether judges are good judges of whether a person should be, I mean, it's kind of tricky stuff to do, but it's at the margins. It's not an enormous segment of the population, but it's something worth thinking about. And then we also want to expand the set of intervention options. In VA, we're only looking at hospitalized or not, but in fact, in the world, there's partial hospitalization or day treatment programs, and there's safety planning, which is not, as it turns out, a routine part of VA care. Maybe once safety planning becomes something that everybody does, the whole calculus changes, and again, best practices outpatient treatment. So there's things we're looking at in all those domains. And we're also, in the MGB study, doing some interesting stuff about evaluating from a precision treatment point of view when you recommend a certain course of action. Are you recommending it in an intent to treat way or a treatment among the treated way? So we could say, look, we don't think this guy should be hospitalized. And if it turns out that we look at it deeply, what we're saying is that we're predicting that this person is not going to follow through with the treatment plan, as opposed to that the hospitalization won't work. So in partial programs at MGH right now, when they say to a person, we don't think you qualify for going to a hospital, but we really think you should try a day treatment program. Here's 5 phone numbers. Good luck. Try to find a program. Well, nobody's going to the program. And so guess what? We're probably going to find that we never want to recommend that. It's not because day treatment doesn't work. It's because they never make it there. So we're doing this interesting thing. Jordan Smaller now and Matt have connected with the Samaritans, which is this big international organization of volunteers. And we're working with Samaritans so that when we do the partial hospitalization program, what it really is we hand them off to a Samaritan who walks them over to the partial hospitalization program. We're not just saying good luck, find something, but we're actually, it's an actual intervention. So how that works, we don't know yet. We're still in the midst of figuring it out. But there's a lot of interesting stuff there about what are the kind of wrinkles in the system, and when you're trying to model some of this stuff, what is it you're doing? And it's generically when we do this, when we more generally do precision treatment kind of stuff, it's really hard to figure out how often you're saying, we don't recommend this treatment for this person. Is it because we predict that this person is not going to engage, or we predict that they're going to engage, and the treatment's not going to work? And I have a few minutes, so let me ramble on for a bit about that, about something totally different. I'm doing this interesting series of trials with college students where we do online therapy for anxiety and depression. And just imagine a simple 2-arm trial where you have sort of a control group and they get into treatment. And we find that it has an effect, 0.3 effect. And then you look at heterogeneity and you find, well, there's actually 2 kinds of people. There's half the people, it has a 0.6 effect. And the other half of people, it has no effect. So we should give it to these people, but we should do something else for these people because that's not working. The 0.6 effect and the 0 effect, what's going on? Is it that the treatment is working better or not? So one of the things we've done, and I don't know other people have done this, but it's really kind of interesting, if we go just to the group of people who were randomized to get the treatment. And then we look at whether they got the treatment. And so this is sort of like the next step beyond an IV kind of thing, where you have to assume that there's no interactions. We go inside the group that were assigned to the treatment, and we look at how many treatment sessions they got. And we estimate a model to predict how many treatment sessions they're going to get based on information we knew about them before we randomized them. Then we take that model in a cross-validation framework and we apply it to the whole sample, whether they were in the intervention group or the control group. So now everybody has a predicted probability of engaging with the treatment if you're one of the ones who we happen to assign to treatment. And we estimate a model that has a dummy for did you get assigned to treatment or control, your predicted probability of engaging, the interaction is significant, and we find that for the 60% of people who we say have a probability above 0.5 of doing it, the effect of the intervention is significant. And for the people who we say have a low probability of engaging, the intervention is not significant. So in some ways, this is trivial. I once, many years ago, discovered that pills only work when you take the pill, you know what I mean? But that's kind of not all that exciting, but that's sort of what we're finding here. But the interesting part is that we can tell before the fact which people are which people. So now, we'd really like to say, when we developed that precision treatment rule to begin with, were we doing nothing more than predicting who was going to engage, or were we doing what we typically think we're doing, which is studying whether an intervention works better for some people than others? And there's no real principled way of dividing those two things apart, except now, because we have the precision treatment rule for this first thing, we conclude that as one of the predictors in the larger analysis. Or we can say, let's just go to the 60% of people who we define based on baseline characteristics, or the people likely to engage, and estimate the precision treatment model in them, and interpret it as saying, among the people who are likely to use it, which ones is it going to work for? And see how different that is from in the general thing. So try to decompose in some semi-principled way, and that's kind of what we're trying to do here as well. So let me stop with that and see if we have any questions. Okay.